Most people believe a heart attack happens because an artery slowly fills with plaque. That belief is wrong, and it quietly costs people their lives every single year. What actually triggers most heart attacks is a small, unstable deposit that suddenly ruptures. Understanding that one distinction can genuinely change how you protect your heart starting now. There are really two very different kinds of plaque hiding inside your arteries. A hard plaque is calcified, dense, and relatively stable over long periods of time. Soft plaque is the dangerous one because it stays fragile and prone to rupture. Even a deposit covering only 20% of an artery can trigger disaster. When soft plaque ruptures, your immune system reacts almost instantly to the injury. It floods the site with clotting factors, and that clot blocks the blood flow. The clot, not slow narrowing of the artery, usually causes the heart attack itself. Cholesterol gets blamed constantly, yet the real story is far more complicated than that. Most people only discover a problem after visiting a doctor for routine blood work. Their cholesterol comes back high, and a statin gets prescribed almost immediately afterward. Side effects often follow, yet the underlying root cause frequently goes unaddressed for years. That root cause is exactly what this script is going to unpack for you. Cardiologists often describe cardiovascular disease using two separate stages, downstream and upstream. Downstream is where plaque has already built up and symptoms start appearing clearly. This is also where the eventual heart attack happens, sometimes with fatal results. That downstream collapse is frequently the end result of a process spanning decades. Upstream events are the early biological changes that quietly set the stage for disease. Conventional medicine tends to focus heavily on downstream symptoms rather than upstream causes. Doctors are trained to manage cholesterol numbers, blood pressure readings, and acute emergencies. Root cause upstream biology, unfortunately, receives far less attention inside standard clinical training. To understand upstream disease, you first need to know about the endothelium. The endothelium is an extremely thin layer lining the inside of every artery. It keeps blood flowing smoothly and prevents harmful substances from entering the artery wall. It also helps produce nitric oxide, a molecule that relaxes and widens blood vessels. That delicate endothelial lining can be damaged slowly over many years of exposure. Picture rough sandpaper repeatedly scraping across a smooth, fragile surface inside your body. Smoking is one major source of that damage, alongside chronically elevated blood sugar. Ultra-processed foods loaded with refined ingredients also contribute to endothelial injury over time. Once that lining sustains repeated injury, inflammation develops inside the artery wall itself. Think of it as a small, persistent wound hidden deep inside the vessel. Inflammation signals white blood cells to rush toward the site and begin repairs. That immune response is exactly where cholesterol enters this entire story properly. Standard blood work typically reports total cholesterol alongside separate HDL and LDL measurements. HDL is often called good cholesterol because it carries cholesterol back toward the liver. LDL is often called bad cholesterol because it deposits cholesterol into artery walls. That simple good versus bad framing, however, leaves out one important structural detail entirely. LDL particles actually come in two meaningfully different sizes that matter enormously. Large, buoyant LDL particles tend to float through arteries without causing much damage. Excess carbohydrates that are not immediately burned for energy get converted into triglycerides. When the liver becomes overloaded with triglycerides, it starts producing smaller, denser LDL. These smaller particles linger in the bloodstream far longer than large, buoyant LDL. That extended circulation time makes them considerably more likely to become oxidized eventually. Oxidized particles are what actually trigger the aggressive immune response described earlier here. This entire chain represents one legitimate and well-documented upstream root cause of disease. Now let's address statins, since millions of people take them every single day. Statins work primarily by blocking an enzyme the liver uses to produce cholesterol. They reliably lower LDL cholesterol, and large trials link that drop to fewer heart attacks. That said, the conversation around statin side effects remains genuinely complicated and contested. In February 2026, the Cholesterol Treatment Trialists Collaboration published a large new meta-analysis. Researchers pooled data from 19 randomized trials covering over 123,000 people. They concluded only a handful of commonly reported side effects were truly caused by statins. Muscle symptoms, new-onset diabetes, and several liver-related changes made that shorter list. That conclusion, however, drew real scrutiny from independent researchers and outside bioethicists. Critics pointed out that individual trial data stayed controlled by pharmaceutical companies, not openly shared. The collaboration itself reports receiving no direct industry funding for its coordinating work. Yet many of the underlying trials feeding that pooled analysis were funded by drug makers. There is also a documented history of run-in periods used in earlier statin trials. A run-in period places every participant on the actual drug before randomization even begins. Researchers can then exclude people who react badly before the trial officially starts. Critics argue this can make a drug look safer than it is in general use. None of this proves statins are secretly dangerous or that the science is fabricated. It does mean the debate over statin safety remains legitimately unsettled among researchers. If your doctor recommends a statin, ask specifically about your absolute risk reduction. Also, ask whether cheaper alternatives like ezetimibe or dietary changes could work first. One additional concern involves coenzyme Q10, an important nutrient for cellular energy production. Statins can reduce natural CoQ10 production alongside their intended cholesterol-lowering effect on the liver. Some clinicians recommend CoQ10 supplementation for patients reporting muscle aches while taking statins. The research on this specific strategy remains mixed, so discuss it with your doctor. Beyond statins, newer non-statin medications have expanded treatment options considerably in recent years. PCSK9 inhibitors are injectable drugs that dramatically lower LDL through a different mechanism. Ezetimibe blocks cholesterol absorption in the intestine and pairs well with standard statin therapy. These options give patients and doctors far more flexibility than existed 20 years ago. Now let's discuss a natural compound with genuinely promising, well-documented research behind it. Aged garlic extract has been studied in several randomized, placebo-controlled trials with real patients. Small, dense LDL particles are far more dangerous because they easily penetrate artery walls. A standard cholesterol panel usually cannot distinguish between these two very different particle types. This is exactly why many cardiologists now recommend more advanced lipid testing options. An advanced lipid panel can measure particle size, particle number, and inflammation markers. Large LDL particles generally pass through arterial walls without becoming trapped inside them. Small dense particles, by contrast, become lodged inside the wall and trigger inflammation. Once small dense LDL becomes trapped, white blood cells arrive to respond quickly. A specialized white blood cell called a macrophage begins consuming the trapped particles. Unfortunately, macrophages do not know when to stop consuming oxidized LDL particles. Under a microscope, these overloaded cells look foamy, earning them the nickname foam cells. Those foam cells are essentially bloated white blood cells stuffed with oxidized cholesterol. Over time, many of these overwhelmed cells simply die inside the artery wall. Underneath the thin cap of soft plaque sits far more than cholesterol alone. There's a graveyard of dead immune cells mixed together with calcium deposits. That calcium actually functions like a biological band-aid, stabilizing the unstable lesions somewhat. So when a doctor says cholesterol needs to be lowered, that framing misses something. It does not directly address the underlying immune reaction, the foam cells, or the graveyard. Cholesterol alone is not the complete villain that popular messaging often suggests to people. A widely cited study from UCLA researchers examined this exact question directly. Published in 2009, it analyzed data from over 136,000 patients. These patients had been hospitalized nationwide for heart attacks between 2000 and 2006. About 72% had LDL levels already meeting current national treatment guidelines. Lead researcher Dr. Greg Fonarow noted that guideline targets may simply be set too high. His point was not that cholesterol is irrelevant to cardiovascular disease at all. His point was that LDL guidelines fail to identify many people genuinely at risk. That distinction matters enormously, and it deserves far more attention than it usually gets. More recent research supports expanding beyond simple LDL numbers toward better risk markers. Apolipoprotein B, commonly abbreviated ApoB, measures the actual number of atherogenic particles directly. Multiple large studies now show ApoB predicts cardiovascular events more accurately than LDL alone. In 2026, updated American guidelines began formally recommending ApoB testing for many patients. Lipoprotein a, often written as LPA, is another marker worth knowing about. It is a genetically determined particle that raises cardiovascular risk independent of lifestyle choices. Unlike LDL, LPA does not respond meaningfully to diet, exercise, or most medications. Testing for LPA once in your lifetime can reveal important hidden genetic risk. So what actually causes small, dense LDL particles to form inside the body? The answer traces back to excess triglycerides generated from refined carbohydrate consumption.